Sure. Hi, my name is Vikas Malik. I'm one of ENT consultants. I work in the northwest of England, and I'm based. My NHS is Royal Bolton Hospital. I have worked in the past at Blackpool Foundation Trust, but moved to Bolton a few years ago. And my private work is based again in Greater Manchester, in and around Bolton. Meniere's disease is a very interesting it's a very interesting name because it's one of the disease which has a lot of uncertainties. It's basically a disease of the inner ear where we don't exactly know what causes, but the main hypothesis is there's an increased pressure in the inner ear. And it leads to different symptoms. The common ones is a common triad of things, three things mainly. Vertigo, which is the room spinning around, which can make you feel sick. Hearing loss, ringing and buzzing, and these are the three main ones, with an additional fourth, which is feeling of pressure in the ear. It's a condition. It's interesting. It's a bit overdiagnosed, to be honest, in the primary care. On an average, if you see the incidence of Meniere's disease, it's roughly about 1 in 700 people in the population in the UK get it. And there's a family history of about up to 10 to 20% people. It usually affects 1 year. But again, if you see the data in the literature, the data varies from 2% to as high as 78%. On an average, we believe roughly 1 in 2 patients of Meniere's disease will go on to have it'll go on to affect the second side as well. So it lasts for a few years, and if you didn't treat it, it'll carry on for a few years, and on an average, in about 6 to 8 years' time, it kind of burns out, but leaves you behind with some problems. Meniere's disease, we can divide Meniere's into 3 main stages. The first is the initial stage, early stage, which is characterized by episodes of vertigo. Vertigo means where you feel the room is spinning. It can make you feel dizzy, of course. It often is associated with a bit of nausea, sometimes vomiting. And usually this vertigo or the rotational spinning of the room or surroundings lasts for about 20 minutes to up to 24 hours. This can be associated with some tinnitus or ringing or buzzing in the ear and some hearing loss. In the early stages, it tends to, as soon as the vertigo settles down, the tinnitus and the hearing loss tend to settle down as well. But as time passes by, as years or months pass by, it evolves in what we call as the second stage or the intermediate stage, where these things become a bit more prominent. The hearing loss especially becomes a bit more prominent. The tinnitus becomes a bit more prominent. And often the vertigo leaves behind, once the vertigo settles down, when you stop feeling the room spinning, often it leaves behind a bit of imbalance. And this can again carry on for a few years. And then it leads to the final stage or the third stage, where often the vertigo settles down or more or less stops. But patients end up with permanent hearing loss and tinnitus or ringing or buzzing in the ear, which are the main problems. So it's very difficult to say absolutely have three definite, absolutely divide into 3 stages and often merge into each other. Meniere's itself doesn't cause serious issues, but of course, Meniere's leaves behind with the hearing loss, tinnitus, which can be very annoying for the patients, and imbalance in long term. Once the vertigo or the spinning episodes finish, it leads to some end damage to the inner ear. And often people feel a bit wobbly, bit unsteady, especially when it gets a bit darker. Now, first of all, how do we diagnose? So Meniere's is classically diagnosed based on history. We do a hearing test. Patients should really have a scan of the ear, the balance nerve and the brain, like MRI scan, if they can tolerate. If not, then CT scan. Then there are some balance tests, and specifically a test for Meniere's called electrocochleography, which if it's positive, it definitely confirms it. However, if it's negative, it does not rule it out. But the scan and the hearing test are the keys. And coming on to the management is mainly based on alleviating the symptoms, controlling the symptoms. And we can kind of, there's a pyramid of, it's a pyramid of management. The base of the pyramid, which works in majority of people, is diet control, reducing the salt intake, looking out for trigger factors. I always ask patients to keep a diary of events, try and identify trigger factors, if there's anything specific which triggers it up, and take care of that. Then, of course, we can have medical management with medications like beta histines, some diuretics in certain patients, or some intratympanic or oral steroids where you can inject some steroid into the ear. And when the patients are having an acute episode where the room is actually spinning, then we give a short lasting a week's course for medications which suppress the balanced organs like prozine. If this didn't work, then we go to the next step ladder, which is an operation called decompression. Roughly about 5 to 10% patients of Ménière's would need some sort of surgical intervention. And if the sac decompression doesn't work, it usually works in about 80% people. If it doesn't work, then there are further options to destroy the inner ear, which I'm not personally very keen on, and I'll try and reserve them for the last possible, as a last resort, because we got to bear in mind it can affect the other ear. And if you permanently damage one side and it starts affecting the inner ear, the opposite side, then it becomes big. So we may manage by diet, by changes in lifestyle, medical management, and if need be, some steroids or sac decompression.